Graduates, colleagues, and friends. It's a great pleasure for me to welcome you all here this evening for the launch of our first dedicated alumni speaker series for the Gulf region. One of the numerous unfortunate impacts of the current pandemic is that we have not been in a position to meet our alumni in person, and so this series offers the chance for us to come together and engage in a digital format instead. It also gives us the chance to highlight and promote some of so many outstanding contributions of our RCSI graduates towards healthcare excellence around the Gulf region. I'm particularly delighted to be invited to introduce the first speaker in the series, Capt Dr Abdulrahman Alshafei, with his presentation on his experience in setting up a pediatric surgery service. Dr. Alshafei is a graduate of RCSI Bahrain Medical School class of 2011, who completed his surgery residency at PDF Hospital here in Bahrain, before taking up a position at Pediatric Surgery Registrar at Our Lady's Children's Hospital in Crumlin, Dublin. During that time, Dr. Alshafei completed a research and a taught master in surgery at RCSI, and then moved to England to pursue a fellowship from the Department of Pediatric Urology at the University of Manchester's Medical School. He returned to PDF last year as a pediatric surgeon and pediatric urology specialist, and was worthy recipient of RCSI Bahrain Inspiring Excellence Award in 2020. I'm delighted now to pass to Dr. Alshafei to deliver his presentation. Thank you.
Yeah. So thanks, Prof. Samir, and thank you, Tom, for the kind introduction. And thanks again for setting up this Gulf webinar series. It's a great way for us to obviously keep the lines of communications open and have just some sense of normalcy during these challenging COVID times. I'm happy to be here to kick things off with the webinar series, and I thought today I'd just talk about setting up my experiences with setting up a pediatric surgery service. As Prof. Samir mentioned, I returned about 6 months ago and was tasked with the responsibility to start up a pediatric surgery service in one of 3 tertiary centers in Bahrain, the Bahrain Defense Force Hospital. And so today I just thought I'd talk about the last 6 months and how they've been. I hope you enjoy it. I look forward to any feedback, any comments, or even advice on the matter. Next slide, please. So just thought I'd start with a bit of history. As some of you may know, pediatric surgery as a specialty is a comparatively new specialty. So it was only formally recognized following the Second World War. Many of us consider William E. Ladd the founder of pediatric surgery. He's a surgeon from Boston who responded to an ammunition ship explosion in 1917 in Canada, where obviously many children were hurt. He's well known for his surgical technique, the Ladd procedure for malrotation, but has also made significant contributions to the field of pediatric surgery, including cleft lip and palate surgery, bladder exstrophy, Wilms tumor. Next slide. And so following the work of Dr. Ladd, obviously there came many highly intelligent and very innovative surgeons, and this list doesn't do them justice. But they quickly realized and recognized that when a surgeon dedicated his practice to the surgical care of children, then the outcomes were significantly better. And this was at a time when past surgeons who did operations on children were generally general surgeons who had an interest in pediatric surgery. And so they were met with a bit of resistance to get this field recognized. Some notable mentions, Sir Dennis Brown, who is considered the father of pediatric surgery in England and was the first to give up his adult patients Some Irish surgeons include Edward Kiley, who's famous for his work in neuroblastoma and conjoint twins. Barry O'Donnell was the first full-time pediatric surgeon in Ireland in the 1950s, and he, along with Professor Premature, who I had the privilege of meeting during my time in Dublin, popularized the STINK procedure, which you see on the right-hand side of your screen, for vesicular ureteric reflux, which we still use today, and something that I offer today in my hospital, among many others. Next slide. And so something that I noticed when I got back was having to repeatedly explain what is pediatric surgery. Understandably, people would come up to me and ask me, well, what does the service offer? How is it different than the procedures or the services provided by the general surgeons? And so I think it's important early on to try to define the specialty. When defining it, it's important to remember that it is the surgical care of children from fetus to adolescent. And I stress the point of fetus because that's when pediatric surgeons are involved, and it's during the antenatal period in counseling parents and establishing that report very early on, which obviously makes things a whole lot easier postnatally. And so although past surgeons could have probably been able to do everything on this list on the left, I think nowadays there is a tendency for subspecializations. And so subspecialties such as cardiac surgery, orthopedics, neurosurgery, and ENT have taken on the responsibility themselves to dedicate and for the care of children, and they offer fellowship training in pediatrics. But generally, the rest of the list there at the top, including general and neonatal surgery, pediatric urology is a big part of pediatric surgery, oncology, trauma and thoracic surgery. These are still the responsibility of the pediatric surgeon. Next slide. And so an important message to get out there early on, and I have to admit the pediatricians and neonatologists were probably ahead of us in this aspect, is the message that infants and children are not just little adults. And I think this picture explains it better than anything. It is not just a matter of needing specialist expertise or specialist equipment, but also understanding the physiology of these babies and their presentation and response to illness, the response to medications, the importance of thermoregulation, for example, and also to understand that they're undergoing or in a period of dynamic neurodevelopment. And so everything we do has to be weighed against the risk of long-term harm. And so it's our responsibility to make sure that these babies grow up to be normally functioning adults. Next slide. And so when starting any new service, pediatric surgery or otherwise, it's important to remember that safety has to come first. Unfortunately, there is no book on the subject on how to start a new service, but what I do know is that it is impossible without leadership. So I'm very lucky in that aspect, and that my superiors, namely Professor Khalid Khalifa, the director of my hospital, shares this vision of advancing the surgical care of children, not just in our hospital, but in the region. And so I think if that is a problem in your center, your country, I think that's where the focus should be early on. It's very important to work very closely with other heads of departments, including surgical colleagues, anesthetic colleagues, pediatricians, radiology and nursing, and very early on proactively managing any issues which may arise and establishing protocols. It's important to be patient very early on and maybe even selective, not taking on too much, more than your resources allow. Next slide. And so one of the big challenges, obviously, when starting a pediatric surgery service is the anesthetic aspect. Again, I'm very lucky to work with top anesthetists and who are very versatile, and we're very keen to take on this challenge of managing and dealing with children. Lots of things to consider when it comes to anesthesia. It's well established that premature children, for example, babies and infants have the highest risk of morbidity and mortality. They have a higher risk of decompensation with any alteration in, for example, ventilation and blood pressure. And so that is something that we have to be wary of. They are at higher risk of congenital cardiac defects, for example, fluid losses, thermal regulation in the theater room. Emergence delirium is much more common in children, and so it's equally important to have a child-friendly environment in theater pre and post-op to try to reduce that. Next slide. So again, there are many nursing challenges that we had to consider early on, and it's unfair for us surgeons to be performing major operations on children and just expect the nurses to manage them post-op. And nurses are heavily involved in the post-op care of these children in terms of pain management, again, parental counseling and education. So it is the surgeon's responsibility to make sure that the nurses are well prepared for this. And again, thankfully, I've been working very closely with our nursing colleagues, and we have made significant progress so far. Stoma and peg care, again, it's very important to be aware not just of the different equipment needed, but also the fact that these children, for example, are significantly higher risk of skin excoriation and ways to deal with it. And so the surgeon early on, as I was heavily involved in the management of these patients and making sure that you are always in close contact and always available to the nurses. Next slide. And so if we consider Bahrain's population, in reality, I mean, we have a small population, 1.7 million people. 25% include the 0 to 18 age group, and so there is certainly demand for specialized pediatric surgery care. However, when we consider the number of live births, for example, in 2020, there were 22,000 live births. And so I think this is probably going to be the biggest challenge for us as a region going forward. As we know, the notion of volume promoting specialist expertise is not something new in surgery. For example, trauma centers are the easiest example to give. And so when we consider complex neonatal illnesses, for example, like esophageal atresia, congenital diaphragmatic hernia, and other complex urological problems like complex hypospadias, any obstructive uropathies, we are only, I mean, in reality, going to see about a handful of these cases per year, considering our population and our live births. Next slide. And so it is really our responsibility to keep up with international standards, and this idea of centralization of care, as I mentioned, trauma centers are the best example, but it's not anything new. It's the exact reason why we have pediatric centers around the world, and some examples here include congenital diaphragmatic hernia repairs in Ireland, who all go to one center. Biliary atresia, again, in the UK, only go to 3 centers, and I believe Ireland have recently enrolled in that program, and bladder exstrophy again. So all very rare anomalies, and so we have to be realistic and have to make sure that these children are being treated in high volume centers. And high volume centers means sharing of care and collaboration between hospitals. Next slide, please. So how do we get there? Well, I think we need to start with establishing a pediatric surgical and nursing society in the region. We need to hold morbidity and mortality meetings, MDT meetings, and we need to perform regional audits and research with the final aim, of course, of sharing the care of these sick babies and hopefully eventually centralization of these rare anomalies. Next slide. And so it's hard to get through a lecture these days without talking a bit about COVID-19, which has obviously been very challenging for us. Fortunately, children only make about 10 to 15% of COVID cases, and they do not get as sick as adult patients. However, something we need to be wary of is that pregnant women, for example, are at higher risk of getting sick, and so we need to be proactive. And although we don't have the results yet, but there is a risk of an increased number of premature births, and of course all the surgical implications of that. The one condition that arose and is thought to believe to be related to the COVID or 19 virus is this post-viral syndrome. If there are any pediatricians in the audience, they would know it's been called the Kawasaki-like syndrome. After 8 cases arose, I think early on in the UK, it seems to follow a similar temporal pattern to COVID-19. And these children often present with GI symptoms really more than anything else. And so we have to be cognizant of that fact. And children commonly present with abdominal pain, which may be due to appendicitis or other conditions. And so we have to be aware of this. Next slide, please. So obviously in the last 6 months, so what have we been able to achieve? Well, we have a dedicated neonatal ICU unit with 26 beds, and now we've been able to dedicate a pediatric surgery and urology theatre list and numerous pediatric surgery urology clinics. Next slide, please. And I think we have come a long way. We went from offering almost no pediatric surgery services to offering a vast spectrum of diagnostic and interventional strategies for these sick babies. And that is definitely something that I think is an achievement we're proud of. Next slide, please. One of my interests coming back, and I'm sure my colleagues would know this, is my interest in pediatric urology. And one of the things I found when I arrived here is that we do have a significant number of children with complex urogenital problems, such as hypospadias, as shown on the left lower part of the screen, and then spina bifida. And it might be related to the fact that it is the COVID-19 period where, and a lot of these children were often referred to countries abroad for treatment, but now we're unfortunately could not travel, and so we're having trouble finding specialist advice. Next slide, please. One of the very common conditions here in Bahrain is spina bifida, which occurs in about 1 in 1,000 live births. And again, these children frankly had nowhere to go, and were now in their teens and having a lot of problems with wetting and soiling, and we're just looking for some sense of normalcy and ways to cope with their disease. Those who deal with spina bifida will know that children with spina bifida often have scarred kidneys. Their kidneys are at significant risk, and they're at significant risk of renal replacement or renal transplant later on in life. And so it is extremely important that these children are managed proactively, which is something now that we are offering, having now established a spina bifida clinic. So things like intermittent catheterization, these children can now finally be offered continent bladder and bowel reconstructions, and finally be able to cope in schools and so on. I cannot overstate the importance of having good psychology support, and I'm very happy to say that I have my psychology colleagues are very keen in joining this mission. These children obviously need lifelong surveillance and a proper transition to adult services as well. The picture on the right is an example of one way to establish continence in these children, continence of urine, using a Mitrofanoff appendicovesicostomy. In other words, using the appendix to establish a conduit between the bladder and the abdominal wall and establish catheterizations for children who can't catheterize themselves, who may be wheelchair bound or for other reasons. Next slide, please. I'm also happy to say that we have established partnerships with one of the companies making some specialist equipment, and we've been able to get some of the best equipment for bowel and bladder control, and involve these companies in providing specialist reps and nurses who are trained and coming over and teaching these children how to use this equipment. The boy on the picture on the left, she shows a boy who was about to catheterize the Mitrofanoff that I've just mentioned in the previous slide. The top right corner is the Parastene washout, which is very commonly used in Europe to help treat problems with soiling in these children. Next slide, please. And so one of the other things that we've brought on and we've changed in our center, and this is evidence that actually, you don't have to be able to do any fancy operations to make a big impact. Sometimes the smallest changes make a massive difference. As we know, in our culture, circumcisions are probably the most commonly performed operation. We perform about 15 plastable circumcisions per week, and the picture on the bottom left is a picture of the plastable method with the tie around. This plastable stays on the penis for about 7 to 10 days and then falls off by itself. And one of the things that I noticed is that it's usually done with a local anesthetic cream, as it is done and it's done the same way in several centers here in the region and around the world. And one of the simple things that we added was the use of routine penile blocks, along with ring blocks and just some sugar water during the procedure. And I'm very happy to say that the feedback we got was just amazing. Mothers would come to us and ask us to do it the new way, where our children don't have to cry, and so and not just from the parents as well, but the nurses, my nursing colleagues as well in the day unit. And so I think this is, I would consider this one of our proudest achievements so far. And so if you are in a center that still uses simple local anesthetic creams to do these procedures, I urge you, please, it really doesn't have to hurt. Next slide, please. So another thing we noticed I noticed when I first came was that there was a significant spike in foreign body ingestions in the country. It's interesting because I think it might be due to a couple of reasons. One is the arrival of some new magnetic toys or toys used in educations or just for fun for children. Some of these magnets are quite strong. The substances used in them are not like the old magnets that we used to play with. And I think the other reason probably has to do with COVID and the fact that most of these children now are in lockdown and staying at home. But we have had a spike of these cases in our hospital, a couple of which have been life-threatening. And so this is one example of the magnetic beads that were swallowed by a 3-year-old girl who presented with multiple perforations in her bowel. Next slide, please. Again, and just another example of the fridge magnets swallowed by an infant boy without the awareness of the parents, and who presented very sick actually with a twisted segment of bowel, which you can see dusky on the right hand side of your screen. Next slide. So again, more examples, and it's equally important that emergency physicians are aware of the dangers of these foreign bodies. The left side X-ray shows that the classic appearance, the halo effect on a button battery, esophageal button battery, and some of you may know these can cause esophageal perforations in as short as 2 hours after ingestion. And so we always urge our emergency colleagues to treat this like a trauma situation. And of course, I don't think I need a caption to explain what this boy swallowed on the right-hand side. But again, just to show that these are just a few of the cases we've seen in the last couple of months. And till now, I don't have an explanation for the reason that we're seeing a spike in these cases. Next slide. Again, and just another example of 100 fills causing a lot of damage in a boy with an obstruction of his stomach, who again presented with vomiting. Next slide. All right, so that's it from me. I am very happy again to be here. Well, my final remarks is that, well, I think establishing any service, pediatric surgery or otherwise, cannot be done alone. It requires a team-based approach. We cannot overstate the importance of education and research when it comes to nursing, and of course our residents. This is a picture of our state-of-the-art research center in the BDF hospital, and I urge you to, and I welcome you to come visit it whenever you're in the country, post-COVID most likely. And so, yeah, safety comes first, and we have been very safe, and thankfully we've been able to achieve a lot over the last 6 months. I'm not sure if any of my pediatric surgery colleagues in the region are going to be listening, but obviously I look forward to working more closely with you over the next over many years to come. And I look forward to any feedback, comments, or any questions you may have for me. I've put down my email here, so please feel free to send me your comments. Thank you.